Hello, this is an EBP group project by Marianne, Carla, Joe, John, and Danielle. We hope you enjoy. So, to begin, we wanted to do our evidence based practice research project on whether eye movement desensitization and reprocessing treatment was more effective or as effective as cognitive behavioral therapy for post traumatic stress disorder treatment. Um, when it comes to mental health, there's a lot of research on both of these types of treatment, and so we wanted to compare the two and see how they fared against maybe different types of people and different reasons for why they have PTSD and other variables that might be in play when it comes to post traumatic stress disorder. What exactly is post traumatic stress disorder? Well, post traumatic stress disorder, or PTSD for short, is a mental health condition characterized by flashbacks, nightmares, and severe anxiety related to a perceived traumatic event. Symptoms must last longer than 4 weeks to be diagnosed, and triggers may initiate severe anxiety and can greatly affect the patient's everyday quality of life. Here's a photo about how PTSD affects the brain. Two current treatments for PTSD include EMDR and CBT. To begin, EMDR stands for eye movement desensitization and reprocessing, and it's a type of psychotherapy that is used to treat PTSD. CBT is known as cognitive behavioral therapy, which is also a treatment for many different mental health disorders. When comparing EMDR to CBT, you can see that EMDR treats PTSD specifically, while CBT can be used to treat many different cognitive disorders. CBT works to be done outside of sessions, writing about events and progression through therapy, and EMDR does not require any outside work. CBT offers a written form of therapy that can be done from a distant location, and EMDR requires the patient to be present for all sessions. EMDR was created in the late 1900s, while CBT has been around since 1960s. CBT uses verbal communication and discussion about past traumas and events. EMDR does not require any discussion, only mental recall of past traumas. Both are considered short-term therapies. EMDR consists of 6 to 8 sessions once a week, while CBT consists of 8 to 10 sessions once a week. So on the left, you see a brain before EMDR treatment, and the person with PTSD will have a lot of overactivity in their brain, and you see a lot of energy kind of working itself in the actual brain tissue. Whereas compared to the left, post EMDR treatment brain, you see a lot of that red overactivity area has greatly reduced, and that is because the treatment over a short amount of time kind of reduces the body's little mental response to those triggers that that person might have to the traumatic experiences that they experiences throughout their life.
Okay, so what is CBT? CBT stands for Cognitive Behavioral Therapy, and its sole purpose is to change a person's cognitive processes. So the components that consists of that are thoughts, feelings, and behaviors. With CBT, it's like a psychological type of treatment, and those are the three components that we focus on when it comes to this. These three correlate with one another essentially because if you think about it, our thoughts help to convey our feelings in certain situations, and in turn, that can cause a certain person to behave a certain way or act a certain way as well. Now, the chart below that just shows a few ways that how CBT works. It shows pretty much how it changes a person's psychological attitudes, and treatment does take a bit of time. If you read the clock down there, it actually says that it could take as long as 4 months or 16 weeks. So it is more of a long-term solution than a short term. And then there is that cycle down there that just shows how they correlate with one another. And it says thoughts create feelings, feelings create behaviors, and then behaviors reinforce thoughts. So they do coincide with one another, and they help each other out. When it comes to EMDR, or another way to say is eye movement desensitization and reprocessing, it's more so focused on a person's traumatic experiences and their attitudes based on those experiences. So essentially, the client is told to recall the traumatic event, and along with that, they may implement an external stimuli, whether that be um, movement of the eyes, hand tapping, or some sort of audio stimulation. And the goal for this is to give the client a better quality of life and reduce those PTSD symptoms associated with those traumatic events. And it's going to give them a way to overcome those thoughts and behaviors as well. And in regards to duration, it's the same way. It's just like CBT. EMDR has a it does take some time, and the recovery of the client ultimately depends on the person's traumatic experiences, because some people have more severe traumatic experiences than others, and it may take them longer to um, see an effectiveness to the treatment. And down below that, it just says what is EMDR. We kind of already gone over that, but it does show a few examples of traumatic events that it may treat. If you just read it, it does say it right there. So death, a witness of a death or injury, combat. So like let's say if you were in the military, you may have experiences with that. Sexual assault, accidents, natural disasters, and sexual abuse as well. Could be child sexual abuse as well. Obviously, because like children do have a tendency to, um, it has a tendency to affect them more than because they're so young. And yeah, those are just a few treatments that EMDR may go through and try to treat. So
Here's a look inside our EBP poster.
This study was a single-blind randomized trial with 3 arms that was to study PTSD in children, 23 different children between the ages of 8 and 18. The 3 random arms of the trial were cognitive behavioral written therapy, EMDR, and then a waitlist control group. Each of these individuals were given 6 weeks of one appointment each week that lasted 45 minutes. No homework, no parental involvement really, other than getting them to the appointments if they were doing EMDR. The waitlist group received treatment after waiting 6 weeks, and the idea was to compare the immediate treatment versus waiting for treatment, and they hypothesized that EMDR or cognitive behavioral written therapy would be better treated, better outcomes than the waitlist group. There were 21 licensed therapists who conducted this, and each was trained in EMDR and cognitive behavioral written therapy. And there were review sessions and videotaped sessions that were watched after each week. And there were follow-up appointments at 3 months and 12 months, and what they found was that these patients had maintained successful treatment at those 3-month and 12-month follow-up appointments, and that overall there was no significant difference between the EMDR therapy and the cognitive behavioral written therapy, other than the EMDR therapy required less treatment sessions for a total of 2 hours and 20 minutes rather than the 3 hours and 47 minutes for the cognitive behavioral written therapy. Drawbacks to this study are that it was focused on youth 8 to 18, no younger than 8 years old, and it was particularly for patients who only had one significant event that was causing the PTSD.
So for this study, it was interesting due to its direct comparison between cognitive behavioral therapy, also known as CBT, eye movement desensitization and reprocessing therapy, which is known as EMDR, and a control group. The group initially comprised of 139 Iranian children. These children were either known to be physically abused or came from families that had a history of domestic abuse. And over the course of the study, that number went from 139 down to 102 participants who actually completed the study. The intervention occurred over 12 weeks total, So for the CBT treatment, that took place from anywhere from 6 to 12 weeks, and each session lasted from 45 to 60 minutes, depending on the situation. On top of that, they also required an additional 10 to 15 hours of homework to be assigned, and we know how children love their homework. And then on the EMDR treatment, this took place for a strict 12 weeks, and treatments were also 45 to 60 minutes apiece, and no homework was assigned. For the assessment scales, 3 primary scales were used to assess the effectiveness of therapy. They were the CROP scales, which stands for Child Report of Post-Traumatic Symptoms, the PROP scales, which is the Parents Report of Post-Traumatic Symptoms, and the Rudder Teacher Scale. So they basically took the perspective of the child, perspective of the parent, and a perspective of the teacher, and directly compared the 3 also. Some interesting outcomes occurred during the process. Initially, teachers' assessment of the child's well-being was amongst the highest of the 3 groups, so they felt that the children were not that they weren't impacted, but they felt out of the 3 groups that they were the least impacted. And after the intervention, they also saw virtually no improvement. So I don't know what could be said about that, but we'll move on to the next one. For both CBT and EMDR treatments, children, they felt on the initial and post-assessments to be they parodied pretty similarly. But EMDR was considered more successful. Ultimately, it had a little bit of a higher score, and I jokingly blame this on EMDR required no homework. And for parents of the CBT group, they felt that their children were negatively impacted on the initial assessment more than the EMDR group. And because of this, that gave them a wider margin of improvement, though EMDR ultimately proved overall to be a better outcome based on the overall score.
For this project, PICO question is: do pediatric patients diagnosed with post-traumatic stress disorder have a more successful treatment with eye movement desensitization and reprocessing than with cognitive behavioral therapy? Of the 2 studies that we used in this project, Study 1, our study with 3 arms, the treatments were well tolerated, and the outcomes for post-treatment were EMDR had a 92.5% of patients that didn't meet PTSD criteria, and CBWT had 92% of patients that no longer met PTSD criteria post-treatment. 12 months later, 100% of patients who received EMDR no longer met the criteria for PTSD, and 92.1% of patients who received the cognitive behavioral therapy no longer met the criteria for PTSD. So this study had pretty good results, with EMDR just edging out CBT by about 7.9%. Study 2 was the Iranian study with the children who are sufferers of domestic violence. These sessions showed that EMDR and CBT were both effective, with EMDR again having slightly better outcomes than CBT. Mean CROP scores decreased by 7.6 points for CBT, and EMDR's CROPs decreased by 9.4 points, compared to the control group who got no treatment of 0.2 points. PROPs showed similar results as CBT scores decreased by 13.2, EMDR decreased by 10.3, and the control increased by 0.7 points. Again, the study showed that while both treatments were pretty effective, the EMDR was just slightly better at decreasing complaints about PTSD symptoms. So in the table below are just descriptions about the 2 studies that we used. Again, our study number 1 was our Dutch study with our 3 arms. It was a single-blind randomized trial with 103 participants. The children were slightly older than the study 2. They were 8 to 18 years old. Our length of the study, however, was shorter. It was only 6 weeks. They had a control group, and the type of trauma that these children suffered from was a single event, such as a car crash or a parent or a loved one dying. Whereas study 2, our Iranian study, it was a quantitative study, so it was based off of the interviews that they took of parents and students and their teachers of their own complaints about their disease process. So it wasn't necessarily based off of the clinician's um, interpretation of the client, more so of the client's own perceptions of themselves. Their population size was a little bit bigger at 139 children, with younger children only 8 to 12 years old. And this study was over 12 weeks, so it was twice as long as the Dutch study. It still had a control group, and this kind of trauma was also different. It was based off of continued domestic violence that they either experienced themselves or witnessed in their home. The relevance to practice and patients for this project was that results appeared to promising for CBT and both CBT and EMDR therapies. Both studies had patients who received EMDR and CBT. They both had improved outlooks and reduced symptoms when compared to pre and post therapy results. Both therapies could be used separately or together based on patient needs, which is pretty much up to the clinician. Results also can vary on the commitment to therapy, the time they have at home, their travel time if you need to travel to the doctor's office, and some of the studies had homework for the CBT. So if you know a patient doesn't have a good home life, maybe you would lean more towards EMDR since it doesn't have as much homework that they need to do away from the sessions. Again, home environment is plays a big part in therapy. Parental and caregiver oversight, again, because it has less involvement by others and no homework involved. Patient age at intervention is also a big clue as to results. Time between treatment and intervention, or between trauma and intervention, and individual responses to re-exposure to trauma are all things that can affect treatment. Finally, we believe that there could be some improvements to this research. There are a lot of studies that support both EMDR and CBT in the treatment of PTSD. While CBT is a short-term treatment and may take months to years to fully treat a patient, whereas EMDR effectively treats patients in a shorter time frame. For those who are experiencing treatment-resistant PTSD, a combination of both treatments may also be effective. There are several suggestions to further the improvement of treatment methods for PTSD, which includes utilizing a combination of EMDR and CBT, which we already talked about, creating studies to broaden the population of patients, which would include probably greater diversity in the population pool, such as age, ethnicity, cultural considerations, and different types of trauma, which would include like war veterans, victims of accidents, or natural disasters. And then current studies are based on these older treatments that have been done for decades. Updating the methods to include technology and create a more accessible treatment would be ideal, especially for the younger generation who is so technologically driven.
So for our EBP project, we also made a little brochure that went along with our poster in a little informational pocket. So here's just a preview of what it looks like and what we created.
And this concludes our EBP project. I hope you guys enjoyed. Thank you.